Hello, leaders of the world. Welcome to Spread Love in Organizations, a podcast for purpose-driven healthcare leaders striving to make life better around the world by leading their teams with genuine care, servant leadership, and love. I'm Naji, your host, joined today by Dheera Ananthakrishnan, an academic orthopedic spine surgeon currently practicing at Emory Healthcare in Atlanta. Dheera is also a philanthropist and entrepreneur, having worked with Médecins Sans Frontières, Doctors Without Borders in Nigeria, and the World Health Organization in Switzerland before moving back to the US. In addition, Dheera is co-founder of Orthopedic Link, a nonprofit that matches unused orthopedic implants with surgeons and hospitals in developing countries. She has also most recently co-founded Women's Musculoskeletal Initiative. Dheera, it's a real honor and pleasure to see you again and have you with me today.
Thanks, Naji. I'm happy to be here.
Can you first share with us your personal story from breaking your leg at the age of 10 to then your love of math, of orthopedics, and your inspiring journey as a surgeon, philanthropist, and entrepreneur in healthcare?
Oh, sure. Yes, I'd be happy to. I grew up in Poughkeepsie, New York, which is a little bit north of New York City, and I was born and raised there in Poughkeepsie. My parents are immigrants from India. They met and married in New York, and I was a real tomboy growing up, and really got into a lot of like dissecting animals and running experiments, and these kind of culminated in me breaking my leg when I was 10. And I had a huge crush on my orthopedic surgeon, and I pretty much decided the day that he flipped those x-rays up that I said I wanted to really be just like him. So this became my driving force. I fell in love with orthopedics, and it's like 40 years later and I'm still in love with orthopedics. And I actually ended up I thought I would go to kind of just straight to medical school, major in biology, and then my father, who was an engineer in India, he went to Indian Institute of Technology, and Illinois came to the US and to go to the other IIT, the Illinois Institute of Technology. He was like set on me going to MIT. And I was like, I don't know, I don't really want to go. But he said, you know what, we're going to go. I said, all right, fine, we'll go. And the minute I walked onto the campus, I was sold. I felt this amazing energy. And I've been lucky enough, like you, to have gone back also, and it's still got that same energy. So I went to MIT as an undergrad, and I was planning on majoring in biology. And I didn't really fit in with the biology kids so much, but I really liked my math classes, and I got involved in a prosthetic project in Woody Flowers' lab. Now, Woody Flowers, unfortunately, I think he just passed away like last year, but he's an icon at MIT and mechanical engineering professor. And so I decided to major in mechanical engineering and plan on going to medical school. So that brings me to getting to medical school. And then that was tough, actually. I recently gave a couple of talks, and I had at least one C on my transcript as an undergraduate, and I had some undergrads at MIT ask me, how did you get into medical school with a C on your transcript? It really wasn't easy, but MIT was really tough as an undergrad, but it really taught me a lot about problem solving and about being humble and learning new things, and that served me well. But I had a lot of struggles getting into orthopedics, and then even going through residency. We had a particularly brutal residency in Chicago, and it was tough. But it's all been I would say 20 plus years of doing this as a surgeon. There have been ups and downs, but I would say overall trending positive.
Well, thanks for sharing, Dheera, this part of your journey. And as you mentioned, I want to go back to orthopedics and your journey there. You said it wasn't an easy journey, and really now you're one of the most renowned orthopedic surgeon. You take complex spine cases and solve them, fix them, treat patients. Um, what was your biggest learning along the way as you were going through those pieces? You also, I know we talked about this, the part that you're a woman doing orthopedic surgeon. I'm an MD myself, and that was like
Yes.
always the case, like, oh, women don't do this, right? So I'd love to get your perspective as you obviously went through this and achieved what you wanted. What is your learning as you reflect back on your journey?
Yeah, so it's interesting that you say that because I actually got those messages really early. Like when I decided at age 10 I was going to be an orthopedic surgeon, and then you go to dinners with your parents and people would say, "Oh, what do you think you're going to be? You're going to be a doctor like your mom." My mom is a pediatrician, and I said, "Actually, I'm going to be an orthopedic surgeon." And it's amazing to me how just a chance encounter people will take the opportunity to discourage, right? Like the first thing is like, "Oh, well, that's really difficult," or girls don't do those things. And the like immediate, almost visceral response is a negative, which to me is like, it's terrible, right? I mean, why would you say that to somebody? um what happened to me was it actually was very motivating for me. Like, I'll show you, you think I can't do it, I'll show you. And fortunately or unfortunately, that's actually become a lot of my life has been like that, right? Used to swimming against the tide, used to, it's like, oh, somebody thinks I can't do that, I'm going to show you, I'm going to do this. And it becomes almost like a part of, like, I don't know, I can't remember not being like that, like not feeling that kind of like drive to like almost to prove people wrong. So like, you tell me I can't do it, I'm going to do it. It might take me a really long time. I might get a C. I might like cross over the finish line last. That has happened to me in certain athletic endeavors, but I'm going to do it. I'm not going to quit. So to me, it's actually it's funny to me when you ask this question. Like, if I'm reflecting, I'm actually really proud of the C that's on my transcript, because it's easier to drop a class, right, and be like, oh, I'm going to drop that, I don't want the C on my transcript. And I think finishing, I mean, you and I are both in, gone to elite institutions, we're used to being at the top of the game, but like being human and like kind of finishing ugly is not there's a lot to be learned from that. I actually teach our students and residents and fellows that many times you have to like learn, not only learning from your failures, but learning from your struggles and also learning from your successes as well, right? Like just high-fiving and being like, hey, we did a great job. Maybe you did a great job in spite of X, Y, and Z, right? And so doing a deep dive and really reflecting I think is really important. But I would say that discouragement and being the only, I mean, when I was at MIT, I was kind of used to being one of the few women, but like being used to being the only woman in the room and being, the one who's like, well, I'm going to do that thing that you think I can't do. I'm going to do the hardest case. I'm going to, stay the longest. I'm going to just to prove that I can do it. And now it's become a very difficult habit to break, actually.
And you've done it, and I love how you're framing it and really reflecting both on failures, successes, and how you can get better and be even better while taking those challenges. If you think about your experiences within Médecins Sans Frontières, MSF, and WHO, how did those come into play and shape the leader you are now?
Yeah, so I would say that I decided to go take this sabbatical with Médecins Sans Frontières and the WHO uh, because I was having a kind of a crisis of conscience. So I was in my first job in Seattle, and it was my first job as an attending surgeon, and it was tough. I had a lot of struggles. It was a bit lonely, and I had I think, everybody needs like a different environment. This is kind of speaks to the like context of each individual situation, like where you are and what you need and what you get out of things, really vary from place to place. So when I was in Seattle, and I would say if I went there now, it would be very different than going there as a junior surgeon, being sort of, green and kind of being thrown into a very intense environment and where there was a lot of scrutiny. I was the only female spine surgeon. There were quite a few other women orthopedic surgeons, but I was the only female spine surgeon. And I mean, I didn't have very many complications, but every time I had a complication, I was really under a magnifying glass. And then the next week, one of the guys would have a very similar complication and it would just get passed over. And those types of things happen kind of again and again and again. And I was really starting to doubt that maybe, I started thinking, well, maybe all of this like pushing to be an orthopedic surgeon, maybe I'm really not supposed to be an orthopedic surgeon, right? Maybe I am really not good at this, right? Everyone seems to be telling me I'm not good at this, I'm not good at this, I'm not good at this. And that was kind of my message when I was a resident, but it wasn't the message when I was a fellow. And I was hoping that I would be in a better position to, but it was tough. And so I decided that I had wanted to do some developing world work for some time. And I decided I was going to leave Seattle, where I was actually quite miserable. It was sad to be in such a beautiful place and being really miserable. And then I went to work with Doctors Without Borders and the WHO, and I took about a year off before coming to Emory. And I really, that was like a remarkable experience for me, because I went from a place where I was like, I don't know if I know anything. And I got dropped in Nigeria and I realized I knew a lot. I could teach a lot. I was one of the nurses actually I think I was there, I'd been there for about 2 weeks. She came up to me and said, Dr. Dheera, you're the local expert on femoral nailing. And I thought, oh my gosh, if that's true, like that's a problem. And then it turns out it was true and it wasn't a problem. Like I really knew what I was doing. And I was teaching Nigerian surgeons how to do things and how we do things back home and how they could do things better. And it was really a remarkable experience for me. And so that, coupled with just like the other thing that kind of came about at that time was the genesis of the idea for Orthopedic Link, because I mean I would be rounding in the ward with MSF and trying to measure people's legs to see if we had the right size implants for them, and say, you got to wait till next week, the shipment is coming in. And then once I got to Geneva and I was working a little bit with some device companies, and they told me, we have a lot of surplus things that we just throw out, and maybe we can try to kind of work together and see if we can try to solve like a problem on both sides. So it was really a transformative experience for me to pick up and go to a place that was a little bit lawless. I was in Port Harcourt, Nigeria, and I kind of found myself there.
Well, thanks so much for sharing also with vulnerability and humility this experience. I think those are things we rarely talk about, how you feel, the impact of others as you are delivering, especially for people who are humble already and have imposter thoughts. So it's thank you for sharing openly your experience and this part of your journey. Do you want to talk a little bit more about Orthopedic Link? I think you're doing just exceptional work there and helping so many people. So I'd love to hear a little bit more about it and let our audience know about it too.
Yeah, so Orthopedic Link, as I mentioned, it kind of started after I'd been in Nigeria. I got back to start my job at Emory. I was working with um, Jim Kircher, who's a local orthopedic surgeon in town. He was a resident at the time, and his wife, who's a supply chain expert. And he had been asking me about my experience, and I said, it's really kind of strange that even in an organization like Médecins Sans Frontières that we didn't have enough equipment, and that I'd also been talking to these device companies, and he said, this sounds like, and both Jim and his wife Heather were also engineers. We were all like three engineers kind of in the medical arena, and we kind of put our heads together. And we started talking to implant companies, reps, to see, is there, like, do you guys really have surplus lying around? And it turns out they did. Things were, older generation of implants were sitting on a desk collecting dust. And then we had to find a site, and I started going to some international conferences just to try to meet people. And I happened to sit down at lunch next to Dr. Gilbert Cawilan, who's a Filipino surgeon. And he said, he was like it was just serendipity, because he said to me, I'm a Filipino surgeon. I trained in Australia. I trained in Hong Kong. I trained in Canada. I came back home. I have all these skills, and I don't have the equipment to treat the most needy patients that we have. And it was an equipment issue, because they had mostly the infrastructure, and then started trying to work with some other NGOs that were in the space. And we were able to get Orthopedic Link started. That was in 2009 with some older, like first generation Medtronic sophomore Danik equipment for spine surgery. And took that over to the Philippines. And we actually also, based on the WHO assessment tool, created an assessment tool of our own to focus, to drill down on orthopedics. And that's where it started. And we've helped hundreds, I think it's close to 400 patients across multiple countries. We have at least 2 self-sustaining sites. We've worked with the Scoliosis Research Society in Bulgaria, and that place has become a regional site of excellence. And the local surgeons have learned so much just from all kind of related to us initially getting this donation planted there, so that it was really a massive, impactful thing to just bring the implants, leave them there, and allow people to learn with supervision, but not be tethered to purchasing equipment or having to have it shipped in and out. It's been really, it's been really remarkable. We had really grand visions for what it could become. And one lesson I learned from working on this project is that, even if your vision of like a big alliance on one side, like we had this vision for a corporate alliance with all of the device companies on one side and a NGO alliance on the other side, and we would be the go-between. That didn't really happen. But even because even though that didn't happen, we've made a really good impact. And I've learned so much about the industry from other sides, from the side of the donors, from the side of the device companies, from the side of the manufacturers, and also, of course, from all of the surgeons and the patients on the ground, and all the providers.
Wow, as you said, like, it's really remarkable impact that you've done across the globe. You do it every day with your patients. You're doing it with patients in need across the globe. So it's really remarkable work that you've been doing. As you think about all those experiences, Dheera, is there one lesson you would highlight specifically for future generation of women getting in med school, and men, who are with them in med school, or who are in leadership positions in residency, etc., and maybe something that you wish you knew very early on in your journey?
So I think one of the things that happens in medicine, and I can really contrast this to engineering and now with my Sloan experience to the business teaching, is that medicine is a very it's kind of isolating. It's funny, when you and I have talked about this, spreading love in organizations. We don't have much love in our medical organizations. It sounds terrible for me to say that because we're humans taking care of humans and humanity, and there really is not much love. And there's not, even just getting into medical school is so difficult. And it's like you've got to step on other people to get in, right? Which is counterintuitive to what you're trying to do in medicine, I think. And so one of the things that I learned this at MIT, and I learned it, and I feel like I'm learning it every day, but that other people can teach you a lot, right? Like, people, you can always learn things from people. It doesn't matter. They don't have to be another doctor. It doesn't have to be another surgeon can only learn from another surgeon. There's a lot of elitism. And I think it's to our detriment because everyone who is working in a hospital, in a healthcare system, is there to care for a patient. They're there to provide care and to make and hopefully, and I don't know that our healthcare system necessarily does this, but hopefully to make people healthier. I feel like we have a disease care system rather than a healthcare system, and so there could be a lot of conflict in terms of people's motivations. But I think that really trying to collaborate, reach across disciplines, reach across titles, I think a lot of times medical students don't think that nurses can teach them anything, don't think that physical therapists can teach them anything. And I think we have to break down those barriers. We've seen with the COVID pandemic how important nurses are. That I can't do my job. That's one of the things I actually learned when I was in Nigeria, that come in and think that I'm the bomb, and then it turns out that the washerwoman who washes the sterile drapes, her son got sick and she couldn't come in yesterday. No sterile drapes, no surgery. So it becomes very evident how connected we're all connected. And I think, yeah, I feel like we have to bring love into medicine. And it's to your point, I think that it has to start with the younger generation. It's not going to be you and me, Naji.
Well, yeah, we have to inspire, but I agree, it's younger generation who will help out. And I've been, I had the privilege to mentor, teach younger generations. I'm very hopeful when you see what they worry about and the things they are focused on, from the questions, really the social impact they can bring, how to work together. Yes. I'm hopeful we can lead from a place of love and be physicians and treat patients in all industries too, whether yes. in a hospital, in a clinic, in the pharma, biotech industry that I'm in as a physician. I really loved how you framed it. We're all connected, right? Yeah. And truly, we all have the same shared purpose. If we are yes. here, we want to make life better for patients we're serving and caring for. So we all share this. I'd love now to get a reaction to a word I would give you. And the first word is leadership.
Oh. I don't have a good reaction to the word leadership. I actually was at dinner with somebody yesterday who said, we have bosses in medicine and not leaders, which is, I think it's, and I don't want to disparage anyone in particular, but I feel as though we in medicine don't model leadership well. I don't think of myself as a leader, really. Like, I feel like a leader, in my gut, I feel a leader is a person that has a title and is, in charge of a big organization. I know intellectually that's not true, but and I feel that it's very difficult to be a good leader. I do think if you put the word servant in front of leadership, I understand it more. Like I feel that the person, the kind of leader that I would like to be is the person who's in the weeds, in the trenches with people, maybe in the front trying to guide them, but is in there in the mud, leading people through difficult times.
Well, that's the leadership I believe in, and you are definitely and certainly a leader. And there's, titles are very different than actually a leader. You can have a big title, but not being looked up for, not being respected, not being followed. So we had this debate. I know you're
Yes,
certainly a
I know.
leader, and we look up to what you do. What about health equity?
Health equity. Health equity is a tough one because I don't think we have it. I know we don't have it here in the US. And I don't know how to get it because I think it goes back a little bit to what I was saying with um, us as, providers, physicians, and then even in your industry, in the food industry, in the device industry, we actually make more money if people are sicker, which is a counter, like, I don't, I make more money operating on somebody than if I send them to physical therapy, get them to lose X number of pounds, get them to do their exercises every day, and then they're feeling better. And you know what? Maybe they don't need surgery, or maybe they need a less invasive surgery that then I don't make as much money from. So there's there's a conflict of interest, I think, in the system, the way it's set up now. You can see it in the number of procedures that we do, and in the number of medications people are on, in the level of health people have in their ASA rating. And I think it's there's a lack of education, and there's a lack of, maybe ownership is not the right word, but a little bit of a lack of personal responsibility, I think. And there's also learned helplessness. I have a lot of patients that come to me, and you'd mentioned I do a lot of complex deformity surgeries. So they'll have come to me having seen maybe 5 surgeons before. Sometimes they've actually had a surgery that's gone awry. And they're hopeless, they're depressed, they're in pain. Many times they're on narcotics, and they come and they want to fix. They will say that, like, I want you to fix me. And trying to be able to change the situation between I'm a person bringing my car to the mechanic and you're going to fix me, versus we're partners in this, and this is a relationship, and you are going to need to do X, Y, and Z, not only to get ready for surgery, but also afterwards. And there's some things you can control, and there's things you can't control. And if we enter into this relationship, a partnership, a contract, so to speak, then I think people, and actually the interesting thing to me is that when I approach these problems this way, these are complicated problems the patients have, they are very appreciative. They actually feel like they have a little bit of control. Like, it's like, oh, I have a prescription. They're not bouncing from doctor to doctor, getting getting a pain medicine or getting something, and they're being told. I mean, I can tell you, I do all my exercises every day when I'm in clinic because I demonstrate all of them to my patients. Like, you need to do this, this, and this. You need to do it every day. I give them a prescription for health and wellness, and then I say, you know what? You can get yourself to this point, and then we'll be able to do surgery, and your outcomes will be better. And I can tell you, people come to my clinic and they'll say to my nurse, "Oh, I heard Dr. Ananthakrishnan is a hard ass," and she's like, "Yeah, but you're you're gonna like it at the end of the day." Because sometimes people need that. But I do think that our lower socioeconomic statuses really, really struggle. And those are the patients that are lost, I think, with regards to their health. And it's a shame.
And you're bringing a very important point, right, about health holistically, like from prevention to how you take care about your overall health versus like just treating or fixing, as you said, a symptom.
Yeah, no, I was going to say there's a lot of conflict, and this won't be very popular, but I mean, I work at Emory Healthcare, and it's funded by Coca-Cola, right? Like there's an inherent conflict of interest even in the food that we have in our cafeteria. And I mean, I like a Coca-Cola as much as the next person, but I don't think it should be in a hospital. But it's tough to fight against that, right? Because we need the money from Coca-Cola, but one could argue that Coca-Cola is causing, or other soda drinks causing, you can X this part out if you want to, but they're causing problems, right? You're causing problems that then we're having to spend more money to fix. So one could say, well, why can't we just stop causing some problems or try to cause fewer problems? So, but yeah, these are controversial topics. Don't know they're necessarily spreading love, but I think that it's important to, these are the things that are dragging us down, I think, as looking at our healthcare spending and looking at where we fit in the global scheme of things. Other countries, I think, do a better job.
Yeah, no, it is controversial, and I think this is why, as leaders, we need to have those debates, right, and talk about them. And it's not something that it's with or without, right? It's a matter of how you can think of those systems holistically and talk more about, because everything is interlinked, right? Like it's either we want to say things separate, or we want to really think from something we both love, a system dynamic way, and start thinking about those impacts, right? Like you go from prevention to healthcare, and even health being part of a global ecological system. We can go into climate change, right? And all this are interlinked, even though we want to think of them separate. They just are not, right? Like we can go and debate, like, should I go to work running or biking versus taking my car? Like that's another piece, right? Because all of these things are interlinked to health and ecology and the other pieces.
Yeah. And then I think to that point, like it becomes like we become kind of numb to it, or you think, well, what's the difference if I drive my car? Like one day I drive my car, one Coca-Cola, one, you know what I'm saying? Like it's only like when you see it in these small segments, it seems like it's not that big of a deal, but that in aggregate, it's huge and so impactful. So I think that like, how much personal responsibility that each individual person has to to facilitate health and facilitate change it's very difficult. And I mean, you like your car, I'm sure you have a nice car.
So the third word I have is imposter thoughts.
Yeah, imposter thoughts. Those, I had those a lot. I don't have them so much anymore. I actually, to be honest, I'm starting to have them again as I'm like making a career transition. But I can tell you, I think that those have motivated me a lot. So it's like this, yin yang, like good, evil, like the goes back to maybe that, like, I'll show you, I can do it. And then maybe inside, I think, no, I think I can do it. But I also like a challenge. So, but the imposter thoughts, I mean, I can tell you when I first got to Emory, I'm in a group with really world-renowned surgeons and really incredible people. And I kept waiting for the first probably 3 years to have somebody tell me that they made a mistake and I wasn't supposed to be there. I also, I remember reading Sheryl Sandberg's book, Lean In. And she talked about sitting at the table and how like we as women like never sit at the table. And I realized I did the exact same thing. Like even as an attending surgeon, like we had this conference and all of the other attendings would be sitting at the table and I'd always sit at the back, right? And somehow felt uncomfortable sitting at the table. Almost like, yeah, like I'm like, well, I know I belong here. Like on paper, I belong here, but I still feel that I should not sit at the table. And some of it also is it's a little bit scary because if I'm sitting at the table next to all of these world-renowned people, then they're going to expect me to have world-renowned thoughts. right? And I mean, I just feel like I have regular everyday thoughts. So then there's a lot of pressure. Like sometimes if you put yourself in the back, you know, I'm always a sit in the back of the class kind of person. So if you put yourself in the back of the class, maybe you're not going to be expected to kill it every time you raise your hand and say something. So it may be, you know, there's getting rid of the imposter thoughts also puts more pressure on you too, I think. Yeah, I feel like as a spine surgeon, I don't have imposter thoughts anymore for the most part. Say 95% of the time. As a leader, I have a lot of imposter thoughts. And
we all do.
yeah. Well, so that makes me it makes me feel good to hear you say that, because
Oh yeah, every
I
day.
don't know. Every day. Okay, that's helpful. That's helpful
Yeah,
to know.
and there is actually I'll send you the link, but I did a great episode with on imposter thoughts, and I'll share with you the link with some good data and discussions we had specifically on this topic. Like there's some good research actually from MIT about this, so I'll share with you the link right after.
Yeah, I remember we talked a little bit about this at school. Like, is it really real, and does it motivate you? And is it imposter syndrome real?
Yeah, yeah, and it's well, Professor Basma Tawfiq. I don't know if
Yes,
I had
I
the
remember her.
yeah, I had the pleasure to be in one of her classes, and she did great research. I interviewed her. I'll send this to you.
Oh, okay. I'll have to. You've interviewed a lot of people, so it's been hard to catch up on all of your episodes.
That's totally fine. The last one is spread love in organizations.
Ah, I knew we were going to get to this. So, yeah, this was, for whatever reason, I would say this is like really tough for me. Because and it wasn't until I think I shared with you that Khalil Gibran poem about how what you love you bring to your work. And yeah, I think we don't have much love in medicine in organizations, and it makes me sad. Sorry. Yeah, it makes me a little sad. And I would like to think that I've spread love to my patients and to people that work with me. But I think, you know, there's a lot of burnout in medicine. And particularly after COVID, I think it's been really, really difficult for there to really be a lot of love in organizations in medicine. I'm curious to see what you think on your side of the coin, but I think it's been tough. I think doctors have not had the brunt of it as much as nurses have. I think nurses have really not felt the love in healthcare for some time. I think that's a lot of what's driven this issue with funding and the traveling nurses disrupting. It's been very disruptive for our industry to have nurses try to go off and like go across the street and make 5 times as much money working with someone else because they don't want to, like, organizations don't want to pay increased nursing pay. And I do feel if maybe there was a little bit more like love and humanity in healthcare, I think that it would, I feel like that type of motivation, I don't want to say mercenary, but maybe more financially driven exodus from home institutions, that kind of thing would be better. Sorry, didn't mean to get so upset, but it is a bit of a sore subject.
Yeah, and well, thank you to share this transparently and openly and honestly. And you asked me what I think. We started this because I really believe we can have a huge impact as leaders by leading from a place of love, at least making the world better for those around us in small circles, and then literally making the world a better place. And you've been doing it through your work with your patients, with the nonprofits you have. but certainly there's a lack of this in the word, right? When you think even more holistically, I think we are seeing an increasing number of acts of hate, of wars, of hunger, of extremism. But I'm hopeful, I'm still hopeful because there are leaders like you. We love to fix the unfixable and try to, take the hard problem and make it better. And even if it's a small piece with what you shared today, I'm sure you're going to be inspiring other leaders to really believe that they can do things differently and probably not take the examples of those others who lead from a place of hate and, stepping on others to do better. So there's still definitely a lot to do, but I'm hopeful when I talk to leaders like you. You said I had the pleasure to have more than 120 episodes now, and it's all really accomplished leaders who have the same belief. And I really think we will be able to do things differently and lead and deliver, both for patients and also for the different stakeholders in the ecosystem. But doing it from, again, a place of love to deliver even better results, because we can deliver results, right, both ways. It's just a matter, do you deliver it with people and people feeling good about it and wanted to do it again with you and together, or you do it and everyone is burned out and you're in a very terrible mental health, right? I think that's kind of like the difference.
Yeah, no, I completely agree with that. I think sometimes people don't understand what it actually means. Like when you say, okay, we want to spread love, but what does that mean? Like in what you do day to day, right? I don't think anyone would say they're spreading hate, right? But it's also more of like spreading indifference or spreading like disrespect or, like not engaging people. Like people at all walks of life want to have some agency into what their life is like and what their job is like. And you're asking us as leaders, if you're assuming I'm a leader, about bringing love to work, but you want everybody to bring love to work, right? Whether it's the person who's fixing your car or the person who is cleaning the hospital or the person who's making the food, right? And so how do you get those people to feel that they are seen and they are respected and that it makes a difference that they're cooking your food because they're feeding me before I go back into the operating room, right? And I think it can be as simple as saying hello to them and knowing people's names and interacting with them and asking about their family. And then they feel that they're part of the organization and they're helping you. Thanks so much because I'm hungry and I have to go back to finish my surgery. And rather than it being a transactional thing, right? And then, then it's like, okay, well, it doesn't matter if I serve food here or at a prison or at a McDonald's or whatever, like it doesn't matter, right? So I'm going to go where they're going to pay me the most. And that's what's happened, right? Like, so that I think spread love in an organization sounds like a really big idea, but what are you doing as an individual, right? Are you, maybe you're driving your car versus walking. Like maybe one day you just say hi to one other person who's, cleaning the room of your patient or like those types of things. I think that there's a disconnect between what it means and people think it's going to cost something to spread love. That's the other thing. It's like, oh, we don't have time. We don't have the money to spread love. Right.
Yeah.
But that's not true at all. Right. It doesn't cost anything.
Exactly. And I love it because this is all about those small things and practical things that actually made a huge difference. You gave the best example I can ever think of. So thanks so much, Dheera. And we can.
Thank you, Naji.
I'd love to hear your final word of wisdom for healthcare leaders around the world.
My final word of wisdom for healthcare workers around the world is, I think, try to listen to people that are not like you.
I love that. Thanks so much. I could spend hours talking and chatting with you. It's been a real pleasure and honor to have you with me today. Thanks for being here.
Thanks, Naji.
Thank you all for listening to Spread Love in Organizations podcast. Subscribe and connect with us on SpreadLoveIO.com or wherever you listen to podcasts. Most importantly, spread love in your organizations and spread the word around you to inspire others and amplify this movement our world so desperately needs.